Hello, everybody. My name is Alex Amador. I am the student board chairman. And just a quick reminder, if everyone could just type in your name, school, graduation year, and student email in the chat. This is just to keep attendance. Okay. So we are still looking for a student secretary. If anyone's interested in applying for the position. We're looking for a secretary and co-secretary. You can apply at the CSRT website under the student corner page. Their main role is just to take notes during the meeting and keep track of meeting minutes. And this position does come with training, so we'll show you everything that you need to know, and you can be part of the student board for CSRT. Okay. So I want to welcome on Rich Lehrer. He's a continuously practicing radiologic technologist since graduating from X-ray school in 1990. His first technologist position was at a level one trauma center. The experience from the trauma hospital propelled him into education as a clinical coordinator and subsequently as a program director for Santa Rosa Junior College. In addition to teaching, he simultaneously maintained a per diem position until 2021 for a local Sacramento area hospital because he wanted to experience the triumphs and challenges that his students were also experiencing. Presently, he teaches part-time for the Gurnick Academy of Medical Arts in Sacramento, California. Rich continues to participate in volunteer activities for the California Society of Radiologic Technologists. He served on the board of directors from 2011 to 2015 and as the editor-in-chief for CSRT's official journal, the Technogram, for over 10 years. Presently, he serves on the Technogram committee and the venipuncture certification committee as one of the faculty facilitators. He is a lifetime member of CSRT and was presented the Outstanding Service Award in 2020. In addition to the California Society, Rich has also volunteered for the American Society of Radiologic Technologists on the editorial review board for the ASRT scanner and the ASRT review board for upcoming directed readings. Rich is proud of the 800 plus graduates with whom he has interfaced during with
Mhm.
their formal education. He enjoys teaching radiologic technology skills and science to those students who seek a career in diagnostic imaging. Several of his graduates served as models and resources preparing today's presentation titled Get Your Head Straight, The Lost Art of Skull Radiography. Rich, the floor is yours. Thank you for being here.
Well, thank you for a nice introduction, Alex. And I am trying to get my presentation to come up on the screen. I can see it, but I don't think that you guys can.
Not currently.
So let's see, share. And oh, I might have it. Are you seeing me now?
Yeah, we can see the PowerPoint.
Oh, excellent. Well, as I said, thank you for a nice introduction. For those of you who don't know me, my name is Rich Lara. I'm an educator here in the Sacramento area. As Alex said, when I graduated X-ray school in 1990, I went right to work at a level one trauma center. Now, at the trauma center in the 1990s, skull and facial bones radiology was pretty common. And so I could count on doing several of these exams each week, if not more than one in a day. Now, you students recognize that as you start to do more and more of the same exam, you start to learn different things about it that make it easier for you. You develop things that help you get through the exam and remain consistent. I also developed some of these ACEs, and by doing so, I was able to get through the exam with a lot more confidence. And so a couple of years ago, when some of my present students came to me and they said, Rich, guess what? We had a mandible in clinic yesterday. And I said, oh, great. How did it go? And they said, it was terrible. See, there's one guy, and he typically does all of the skull and facial bone radiology, but he's off this week. We got through it, but it was pretty ugly. And it occurred to me in that time that I had I knew what they were going through because skull radiology can be challenging. So I thought back on all of the things that I had learned over the years, and I chose to build this presentation based on that. So, that being said, what will we talk about today? Ooh, I hear something. Okay. Ooh, somebody's mic is on. Turn it off, please. So, I'm going to take you back to BC before CT scan. Okay. And what did we do for skull radiology in the 80 years between the discovery of X-ray and when the CT scanner came available to us? I'm going to talk about some of the pioneers of skull and neuroradiology whose contributions still bear their name in tribute. I've got too many screens going on here. I'm going to talk about procedures and equipment from a time gone by, stuff that we don't do so much anymore. Oh, sorry about that. There I am. I'm going to talk about some common skull and facial bone exams, and I'm going to talk about some approaches to their success. I'm going to spend some time talking about common items in your department that may be used for an aid during skull radiology, stuff that you already have, but you haven't really thought about using it for skull radiography. I'm going to hopefully give you the ability to see straight lines on round heads, and that I hope will increase your confidence to image skull and facial bones competently and confidently. So, before CT scan, we had something called stereoscopy. And stereoscopy an interesting was interesting from the perspective that we would take not one X-ray image, but we would take two. And these two X-ray images would be at 1/10 of the source to image receptor distance, the SID. Back in those days, we called it the focal film distance. And as you know, skull radiography is done at 40 inches. So we would take 4 inches and we would offset the X-ray tube underneath and angle it up. We would angle it cephalad to converge on a certain portion in the on the X-ray plate. And the same thing would be true on the other one. We would bring it above the head and angle it caudal. And we would take two discrepant images that would be side by side, and you can see Juan is looking at these two X-ray images. There, I'm getting rid of that little screen. Good, that's better. And through the viewer, it gave the illusion of depth, which was pretty cool and very, very popular. And it gained widespread acceptance and popularity, and we used it all the way through the 1930s. But when we found that it was expensive and time consuming, and we started to recognize that it was also some of the hazards associated with radiation exposure, it fell from favor in the 1930s. Perhaps you have heard of pneumoencephalography. And pneumoencephalography, admittedly, is more about the brain than it is about skull and facial bones, but nonetheless, it was too good to let it slide. Pneumoencephalography was quite a brutal exam where we were looking for changes in the shape of the ventricles of the brain. And so you were brought to the X-ray department and you were placed in this special kind of chair, which you were strapped into. Now, this chair, you can see, are you seeing my pointer moving? I'm hoping you can
Yes.
see. Thank you. You
Hmm.
can see that this chair is on a pivot. And so what we could do is we could take this chair and we could rotate it all the way around. And that was valuable because the intent was we were interested in your brain, we were interested in your head, and this was on isocenter, which means that the X-ray beam is constantly going through the same spot in your head. And so the intent here was to do a lumbar puncture and withdraw 10 cc's of CSF, replace that with 10 cc's of air, and then manipulate the brain to fill the ventricles with air. And so this was developed by Walter Dandy in 1919 and was performed all the way through 1970 when CT was introduced into clinical practice. You can see that this person has the lumbar puncture uh, performed, and I don't know at what point in the procedure, but this looks like it's when the air is placed in the spinal canal. And what were the positions? Well, we would start with the patient sitting up, and then we would tip them backwards. And then by number three, we go all the way to supine. And then let's just take the feet right over the top, and you end up prone, and then eventually sitting up again. And what this was designed to do was to introduce the air into the ventricles of the brain. I'm told that this was a very unpleasant procedure. And fortunately, when the scanner came into place, we did away with them. The images, however, were really quite good for the time. And this is a pneumoencephalogram from that time. And you can see here is the corpus callosum, which is air-filled, which is closely associated with the ventricles of the brain. It was Dr. Dandy who was looking for changes in the ventricles and in the corpus callosum to identify if there were lesions that were causing a mass effect on the brain. Okay, we'll fast forward to the 1950s and 60s, the Franklin head unit. I have been trying to find a Franklin head unit. If anybody knows whether there is one somewhere here in the country, please let me know. And I'd like to go and take a look at it and take some pictures of it. But this was really very valuable because it was a lot more elegant than the equipment that we had at the time, and it would allow us to take upright radiographs of the skull and the facial bones. Now, the value here is the X-ray tube was on a pivot, and so we could angle caudal and cephalad. But additionally, the bucky here, the gridded bucky, would stand straight up so that we could get upright radiographs. And so this was tremendously valuable. And these were I'm told that these were also very valuable to do odontoid process as well as shoulders. What did we do if a patient came into the emergency room exhibiting signs of hemorrhagic stroke? Well, nowadays we would take them immediately to the CT scanner, but back in the day we didn't have that. So we would go to the angiography suite and we would perform a internal carotid artery angiogram. And you can see on this image that the vasculature goes all the way out but doesn't go to the inner table of the skull. So what's happening here is this is blood that is pooling and pushing against your skull, and that pushes against your brain. And now we have a midline shift of the right hemisphere of the brain. But when you think about it, isn't that exactly what is happening? What we're looking at when we do CT scans now, where you can see a bloody collection here on the frontal and parietal portion of the brain. And can you see that the right hemisphere is pushed over to the left? So this is what we had before the scanner came along. But this fellow, Sir Godfrey Hounsfield, changed all that by bringing to life the CT scanner, and the first ones were available in the early 1970s. Sir Godfrey was in the English countryside on vacation one year, and he was thinking as he was strolling along the brook about if I could take something and put it in a box and take X-ray images from all around the box, then I could tell what was in the box. And this was the thinking that spawned the realization of how to build a CT scanner. Those early scanners, they required 30 minutes for the scan, and this particular one was only for head scans. We wouldn't be doing body scans for a number of years yet. And then after 30 minutes of scanning, we would take the magnetic tapes to an EMI, electronic musical instruments mainframe computer to process it for 2.5 hours. And that would give us images. You can see some of these images here on the CT couch of Polaroid images of the brain. In the 1950s, a physicist, Alan Carmack, had already developed the necessary calculations that enabled CT, and as a result, the CT scanner, Dr. Hounsfield, as well as Alan Carmack, shared the Nobel Prize in Medicine in 1979. The images that we got back then were not unlike what we're getting today. Take a look at this is regular brain windows, and we have here, can you see the subdural hematoma that extends down? I'm sorry that the bone windows did not reproduce well in this radiograph, but this is, you would recognize this as a CT scan if you saw this Polaroid picture. All right, so CT scan is wonderful. CT scan has certainly revolutionized modern healthcare. However, we should be aware that CT scan is increased radiation. I went to xrayrisk.com, a website that is endorsed by the ASRT, and I typed in for skull x-rays, a male patient, 30 years of age, and number of exams. I figured let's do facial bones, for instance. We're going to do 4 individual images of facial bones, and the dose for all those 4 images is zero point 0.1 millisieverts each, or a total of zero point 0.4 millisievert. Now take a look at sinus CT, almost twice the dose of 4 skull radiographs. And take a look at a brain CT, a standard head, and the dose is 5 times as much. Now, despite the fact that there's a lot of radiation there, it's still, the statistics on the bottom indicate that it's still very safe and probably not going to cause anything. However, I'm thinking about the pediatric population, and I'm thinking about when we desire a simple answer at a reduced dose. Do we always have to go to the CT scanner? And from that perspective, skull radiography and facial bones radiography is going to be around for us for quite some time. And so I want to share with you some good news. There's only about 15 skull and facial bones projections. We use the same positioning, various modifications. It depends on the anatomy that we're trying to image. An example of that is a Waters projection, and I will explain these individual projections a little bit further as we go along. So, Waters projection. You technologists and you students out there, you do Waters for sinus. You do the same Waters projection for facial bones. You do the same Waters projection for nasal bones. How about do we do a Waters projection for pre-screening of MRI on our patients who have a history of working in the trades and concerned that there might be ferrous metal in their eyes? Can we do a modification of the Waters projection for orbits where we don't have as much extension of the head? And so this is what we call a shallow Waters when we're looking for orbits. Can we do an open mouth waters for sphenoid sinus when the sphenoid sinus is what we're particularly interested in, and the patient may not be a good candidate to extend all the way back for a submental vertex? And what about a reverse waters when the patient cannot tolerate a PA projection, or perhaps they're unconscious and on a ventilator? We can still get a waters projection. We just do it AP as opposed to PA. And I'll talk about that in several more slides. Are you with me so far? You hanging on?
Yes.
Thank you.
Good.
Good, good, good. All right. I wouldn't be a good educator if I didn't at least refamiliarize us with the playing field. And so, what we have here are a number of anatomical landmarks which we use in our positioning. And the first one is the glabella. The glabella is that flat spot right here in between your eyes. Okay. And the glabella is useful for us because we're sometimes we're going to image right through it, and sometimes we're going to image several inches above it. The nasion is the bridge of your nose where your glasses are. Okay, also a useful radiographic landmark. The acanthion is that space in between your nose and your upper lip. And the acanthion is generally a place where the exit beam is centered. And then finally, we have the mentum of the chin, or the mental protuberance is that fleshy portion of the chin where it juts out. All of these are good landmarks for us for skull and facial bone radiology. Back in the days when we were in film screen and with computed radiography, we had individual cassettes, and our individual cassettes were 14 by 17, or 11 by 14, or 10 by 12, or 8 by 10 inches. Now, in the modern digital department, we may or may not have that any longer. What we have is a 14 by 17 or a 17 by 17 inch image receptor, a flat panel detector, and that may be in our upright bucky. So, the Good Book of Merrills, now in its 16th edition, for those of you who have been out of school for quite some time, has started to publish suggested field of view sizes for different projections. And for skull, we need to use on a lateral, we need to use an 11-inch horizontal and 9-inch high to include the frontal bone to the occipital bone, to include the vertex of the head and the base of the skull. Okay? Are you guys seeing this chat thing on the bottom here? Is that showing up? All right. I hope not. How about for AP or PA? For AP or PA, we want to see the same anatomy. We want to see from the frontal bone back to the occipital bone. We want to see the vertex of the head, and we want to see the base of the skull. And of course, we want to see from glabellar, from parietal eminence to parietal eminence. So that's for skull. Now, notice on this X-ray image, I don't have the face included because it was a skull that's ordered, and I do not need to include the face on a skull radiograph. Similarly, on a facial exam, I don't need to include the entire head, the entire skull. Facial bones extend from the base of the mandible all the way up to the superciliary arch. Reach your hand to the glabella and go to the left or right, and you feel that arch up there? That's the superciliary arch, and that is considered the most superior portion of the face. So we need to demonstrate everything from the mandible to the superciliary arch and anterior posterior back to the mandibular rami and the temporal mandibular joints. And so you can see that I have that on these images. Here is up to the superciliary arch. Here is the mandibular rami, and the TMJs are in here as well. I think that's one right there. And same thing here. I don't have the rest of the skull because I don't need it. I have from superciliary arch down to the base of the mandible. So on facial bones, where we were using 10 by 12s for skull, facial bones, we were using 8 by 10s. Now Merrill's has identified that for skull radiography, we don't need the full 10 by 12. For facial bones radiology, we don't need the full 8 by 10. And as you know, collimation is your friend, increases the visibility of detail and the spatial resolution and all of those things that you learned in physics and digital imaging. I want to encourage you that when you bring your patient into your x-ray room and you sit them down and you introduce yourself and take two patient identifiers so you know it's the right person, while you're interviewing them and asking them about their present injury and or whether or not they've had any surgery or this kind of problem before and on, I want you to go ahead and take a disinfecting wipe, and I want you to wipe off the bucky, the upright bucky, because we're going to put their face right there. And how many chest x-rays has that bucky seen in the last 48 hours? And has there been anybody who really did wash it off? And what about all of those patients who come in and coughing? Yeah, let's go ahead and disinfect that upright bucky and not spread and not transmit diseases around. And I also want to encourage you that after you have cleaned it off thoroughly, then take a dry paper towel and I want you to wipe it off and make it dry because if you don't do that, your marker won't stick. And don't ask me how I know that, okay? There's a couple of gotchas with skull radiography. There's five of them, and two of them, the first two are rotation and tilt. This is rotation, shaking your head no, side to side. This is rotating. Tilt is tipping your head back and forth this way. We don't want, typically, we don't want rotation, and typically, we don't want tilt. There are a couple of exceptions to that, but those are the exceptions and not the rules. So, looking at straight lines on round heads, I'm going to show you how you can evaluate rotation and tilt. Other gotchas include incorrect flexion or incorrect extension. Sometimes we need the patient to tip their chin way down, and sometimes we need the patient to extend their chin way up. So, how can we tell if we have achieved enough flexion or extension? And the answer is with some standard positioning lines, which I'm also going to get into, I think, in this next couple of slides. Finally, the last gotcha, you should be aware that there may exist an angle, some angulation of the center ray. And if you need an angle, then you need an angle. If you don't need an angle, then for goodness sakes, don't have it on there. So these are the five gotchas, and these are easy to eliminate by carefully positioning and looking for rotation and tilt and flexion and extension and including an angle or not. Okay, your patient is facing toward the board and you don't really know if they're straight and you can't see their face to tell if they're straight, but your hands can tell you. I encourage you to take your hands and put them on each side of the patient's head gently and extend your fingers all the way up to the bucky. If the patient is straight, you'll be able to tell. Your hands will be able to tell you. I think that all of you students have had the opportunity and the experience of positioning for lateral chest x-ray and you put a hand on the patient's scapula and you just know when they're lateral. Your hands can tell you. Your hands are very sensitive. And so I want to encourage you for skull radiography, sit down with one of your classmates, put them up against the upright bucky, And then try this. Put your hand both sides of their head. Ask them to rotate their head a little bit, and you will immediately feel that their head is not straight. And so your hands can tell you. All right. I promised you the ability to see straight lines on round heads, and here are some of the positioning lines that we're going to use in conjunction with those landmarks that I talked about earlier. Now, they all start from the area of the ear, which is the external auditory meatus. Now, the external auditory meatus, interestingly enough, is not in the center of this cartilaginous flap. The external auditory meatus is in the bottom third of that cartilaginous flap. And so if you start from the bottom third and you extend a line all the way up to the outer canthus of the eye where your eyelids come together, that is a standard radiographic positioning line known as the orbital meatal line. And this orbital meatal line needs to be parallel to the floor for some of our radiographs. Same thing with the infraorbital meatal line just below it by about 7 degrees. And the infraorbital meatal line extends from the EAM up to the just below the eyes. The acanthomeatal line from the EAM up to the acanthion, and the mentomeatal line extends from the EAM all the way up to the mentum of the chin. These are four of the seven positioning lines. There's only one other that we commonly use, and two of them we don't really use at all. Common items in your department that may be used as an aid during skull and facial bones radiography. So what do we have? Anybody in your school or in your clinical site, do you have a protractor? Something like this where you can measure angles? This is actually very helpful, especially when we're looking at mandibular x-rays. And we also found it very useful in the days when we did the Reese projection of the orbits, which is not as common anymore as it was. But if you're looking to measure an angle, you can use this protractor. I also use this in positioning lab when we're practicing for Mortise ankles, 15 degrees of internal rotation. So we'll have the students go for position what they think is 15 degrees, and then we'll measure it. And it really is very useful. Paper cups. Have you ever had a wiggly 2-year-old on the table? And did he listen to you and do what it is that you asked him to do? Yeah, they don't listen to me either. But the deal is that we want to minimize patient exposure, especially to the pediatric population. And so we can use a couple of paper cups over the patient's ears. And by doing this, we can now flex or extend or rotate or tilt the patient's head, and your hands will not be in the field of view. Okay, so paper cups work out very well. They don't hurt the child, although the child may scream bloody murder. However, this is a good way to get your image right the first time. Positioning sponges. Now, I know that you have positioning sponges in your department and in your school. And the value of positioning sponges is that they have, on this image here on the left, you can see that this is a small straight sponge, like a rectangle. Okay, and I can put that rectangle, I can put it, the butt end of it, up against the upright bucky. And now I'm going to move it down to the EAM and ask the patient to flex or extend their head until I see a qualified line that shows me that I have, in fact, now put the orbital meatal line parallel to the floor. This is this is now I've gone a long way for good positioning by having the correct line in alignment with the floor of the department. And so what I have here is good positioning. On the image on the right, you can see that Rachel is looking straight at us, and I've used a small positioning sponge to take some of the tilt out of her head. Okay, and I do encourage you to use sponges, even the little ones, because it gives the patient something to brace against. And by bracing against this, they're not going to be able to wiggle around if they have their head out in space. No, give them something to brace against so that they're able to hold still. I sure was excited when laser lights started to be incorporated into X-ray tubes. And the columnator light really helps us by virtue of look at that red laser light. Can anybody dispute the fact that I am right on the mid-sagittal plane? And look at that dark line across the interpupillary line. So what I can see is the red line tells me that I'm not rotated, and the dark line tells me that I'm not tilted. So the columnator light is also quite useful for us in positioning, not just to show us the limits of columnation, but also to show us where the lines are so that I don't have any rotation and I don't have any tilt. How else can I use it? Well, I can put my red laser line, the horizontal one in this case, and you can see that I have the front of it anteriorly at about the level of the infraorbital meatal line, but the back of it posteriorly, it doesn't exactly correspond with the EAM. So from that perspective, I would say, Matt, I need you to tip your chin down just a little bit. Good, hold it right there. And then it's a simple matter of moving my X-ray beam up 2 inches above the EAM for a lateral skull radiograph. I can do the same thing cross table lateral. Here I'm showing the positioning line to the infraorbital meatal line um, and confirming that that is now correct. I can move my central ray up above the ear, and there is my cross table lateral skull. And yes, I will admit that I just told you a little while ago that I'm only interested in the skull, and here I've included the facial bones. Um, the equipment that we have in our lab is not as well maintained as what you may have, or certainly what is in the hospital. And so the columnators are somewhat off, and it just occurred to me that I would show you a good lateral of everything. Common items in your department. Do you have these in your department? These are calipers. Calipers are typically used for measuring. These are really very useful for pediatric patients. If you don't know what technique to use, you can measure them, and then you can use your technique chart that's in every room to determine what your exposure ought to be. So, what else can we do with calipers? Well, have you ever thought of this? I can't find the grid holder, but I can use the calipers to hold my image receptor up and do a cross-table lateral knee. And yeah, that's true, but that's not using calipers for skull radiology. The value of calipers, just like sponges, is that they have a right angle on them. And this right angle can be very useful for helping us to conclusively prove to ourselves that we have the right line parallel to the floor by putting the short end of the caliper along the upright bucky and then orienting it to be sure that the interpupillary line is straight. Then I am convinced now that I don't have any tilt in this head. Additionally, as we look at Rachel, can you see any rotation? How can I tell rotation? I want to encourage you to look at the nose to the ear on the left side and then the nose to the ear on the right side. If those distances are the same, then you are not rotated. If you are rotated, if it's twisted over a little bit, then you will see that one side from the nose to the ear is larger and the other side is smaller. And so you can rotate the patient back and forth until you achieve equidistance between the nose and both ears. How about the mid-sagittal plane? Well, sure. Let's use the slide on the calipers to give us a reference as to whether the mid-sagittal plane is set up. And so now with the calipers set horizontally, I don't have any tilt. And with the calipers set vertically, I don't have any rotation. So I'm good to go. Something new that we came up with this year, one of the students suggested this to me, and this is a speed square or a rafter square. Anybody who has any experience in construction knows that this is a tool that we use for building houses and especially for building rafters of houses. Okay? But it has that same value of a right angle on it. And so by using this, I typically tell the students that I want you to put it up against the Bucky, and then I want you to move it down to the EAM, and then ask the patient to flex or extend their chin, in this case, the mentomeatal line, so that we have conclusively demonstrated that the mentomeatal line is now parallel to the floor. These are available for $2.99 at Harbor Freight. I'm going to assume that Harbor Freight is all over California, but I'm sure that wherever you get tools, you will find something similar. And these the ones that I got are aluminum. So here is, um, will you agree that I have the orbital meatal line parallel to the floor? And I have the orbital meatal line parallel to the floor. All right, this next one is something that you will not find in Merrill's. This is one of my aces. I'm looking at Matt and I'm trying to do a good lateral, okay? And I'm looking at him and I'm right up close to him. And, you know, it looks pretty good, but there's something nagging at me that it just doesn't quite seem right. I don't know. Is his head tilted a little bit? What's going on? I can't see it clearly. That's because I'm too close. I'm going to suggest to you that you employ the rule of social distance, which we all know is 6 feet. So in your x-ray room, typically the floor is made out of tiles and they are 12 inch by 12 inch. So move 6 tiles back and look at Matt again. Now, from this perspective, you have a much better sense for the entire picture. You're not seeing the tree up close. You're seeing the forest and the relationship of the tree to the forest. And by looking at Matt now, I can conclusively determine that the interpupillary line is parallel to the floor, perpendicular to the image receptor, and that the mid-sagittal plane is also parallel to the image receptor. So I'm feeling pretty good about that. Are you with me? You guys hanging on?
Oh yeah.
Okay, good, good, good. Let's talk a little more about some of these individual projections that we're interested in. Lateral facial bones versus lateral sinuses. For facial bones, as I mentioned, facial bones include the mandible. So we need to get the entire mandible on a lateral facial bones projection. And the lateral facial bones projection, the central ray is going to come in at the zygoma between the areas of the external, I'm sorry, yes, the external auditory meatus and the outer canthus of the eye. Okay. It's not on a line between the two, but it is down below just a bit in reference to the zygoma. And you can find exactly where that is in the Merrill's textbook. Now we need to include the mandible. And so here I'm seeing the mandible and some space underneath it. And I need anteriorly all the way back to the ramus of the mandible. And typically I include the EAM so that I know that I'm far enough back. Merrill suggests that we use a 7 by 7 field for lateral facial bones. Now, sinuses are a little different, very similar, but there are some specific differences. We have four sets of sinuses, and we have a frontal sinus up here, and we have a maxillary sinus here. Your maxillary sinus does not extend beyond the palatine bone. You don't have maxillary sinuses in your mouth. So there's no reason to include the entire anything below the lips because the maxillary sinuses are above the lips. And additionally, we need to include the other sinuses, ethmoid sinus, which is behind the nose, and sphenoid sinus, which is behind the ethmoid sinuses. So on a 6 by 6 field, and our central ray is entering approximately 1 inch uh, behind or posterior to the outer canthus of the eye. And by doing this, you will get a grouping of all four pairs of sinuses. Nasal bones. Of course, we have done a Waters projection for the sinuses we just saw, and we also did a Waters projection for the nasal bones. But we also have to take lateral nasal bones, and there are two nasal bones, so you have to do both sides. Good Book of Merrill's, I was very pleased to see, suggests a field of view size 3 inches by 5 inches. 3 inches by 5 inches. Now, students, tell me, is your clinical instructor going to have a heart attack when you columnate down to 3 inches by 5 inches? I have heard it before. Open it up, open it up. Doctor doesn't want to miss anything. Well, what part of the nose are we missing here? What am I seeing? I'm seeing the nasal bones here, and I'm seeing where it articulates with the perpendicular plate of the ethmoid and down here with the maxillary. I'm seeing the end of it and including all of the soft tissue of the nose. This is the top of the eye socket, and here is the alveolar process. So the maxillary sinuses are up in here. Now let's think for a moment about the way digital imaging works. Remember I'm talking about DR now, flat panel detectors. When you make an exposure on a DR detector, the first thing it does is it looks for your limits of collimation. It does not process the entire plate. It looks for the areas that have exposure based on your four-sided collimation, and it says, okay, this is what Rich wants me to do. And so it's going to take a look at that area and that data, and it's going to create a histogram from that. And then we're going to apply the lookup table and automatic rescaling if we need to. Digital imaging can do this. And if we give it just what we want it to see, it's going to give us very good results. If I included half of the skull, then that would dilute some of the fine detail that I'm seeing here on the nose. And so 3 by 5 inches is entirely doable. And I want to encourage you, yeah, go ahead, try it in lab first. And I think that you'll be very pleased with the results that you get. You've heard of a Townes projection, and Dr. Townes in about, I think he published this paper in 1926, was interested in the petrous portion of the temporal bone associated with acoustic nerve tumor. And Dr. Townes was very unhappy with the standard of a lateral image of the skull because he could not see the external auditory meatus. He could not see those that portion of the temporal bone. And although he might see them, it was difficult for him to determine which side was which. And so he developed an AP axial projection. And his description with the patient on his back, the head is flexed at the top of the neck, so the chin is drawn backward. Okay, now we use the orbital meatal line, which is exactly what he said to do. The center of the film is placed under the foramen magnum, central ray directed at the center of the film through the midline of the frontal region at a point about 3 inches above the level of the eyebrows or the glabella. Okay, here's Megan, and we have orbital meatal line parallel to the floor, and the central ray is entering 3 inches above the glabella. And can you appreciate from that red laser line coming down the side, can you see that it exits at about the level of the foramen magnum? Now, if patients cannot achieve, if they can't pull their chin down far enough, then you can use the infraorbital meatal line at 37 degrees of angulation to compensate. And that's entirely fine. So it was Dr. Towns who developed this projection, and we found a number of uses for it. For the apiaxial towns, we can image the occipital bone. For the apiaxial towns, we can bring the central ray down to about an inch above the glabella. And now can you see that central ray is going through the TMJs? And so we can use this to image TMJs. Although when we're doing TMJs, we're going to increase our angle from 30 to 35 degrees with the orbital meatal line. And we can also bring it down a little further, and this will demonstrate the zygomatic arches. Zygomatic arches can be seen on an AP axial Towns projection. Okay, for your patients who are not good candidates for the submento vertex, which we're going to get to here pretty soon as well. And since I opened the bag about TMJs, let's talk about the axiolateral projection of that. The TMJ is actually 1/2 to 1 inch anterior to the external auditory meatus. And the projection that I suggest is the modified Schuler, which is 25 to 30 degrees of caudal angulation. And it's not about the entrance beam, it's about the exit beam. And the exit beam, if you have a good lateral projection and you are centered about 1/2 to 1 inch anterior to the external auditory meatus, then you should get the same thing coming out the other side. Suggested field of view for this is 5 inches by 5 inches. For TMJs, we would like to do open with the mouth open and closed. Um, I caution you that however the patient comes to you, that's how you want to do at least one of them. And if that's closed, then if they can open their mouth, then you should carefully try to do that. If they cannot open their mouth, don't don't push it. Typically with TMJs for the axiolateral, you're going to be doing both sides. Everyone's favorite, submento vertex, where the X-ray beam enters submento below the mandible and enters and exits at the vertex of the head. According to Schuler, who described this in 1905, the infraorbital meatal line is parallel to the image receptor and perpendicular to the central ray. Okay, so infraorbital meatal line parallel to the image receptor. That means I need to tip way back, way back. And so I encourage you to help the patient put a hand on their scapula, help them to tip back until you see that the infraorbital meatal line is parallel to the floor. And at that time, reach your other hand over, grab the tube head and bring that down so that your laser line is planing 3/4 of an inch above the external auditory meatus. And then help the patient sit up again. And by doing that, then you can put your marker on the board and you can bring the bucky down to meet the laser light and then tip them back again. And you should be able to get good results with the submento vertex. So here it is, 3/4 of an inch above the EAM. Okay. And what you want to see is symmetry of the shadow of the face. On both of these images, can you see symmetry? One side looks pretty much as does the other. So I'm not rotated and I'm not tilted. Now, what else can we do with submento vertex? Well, from the same position, I can bring my X-ray beam up a little higher and I can image, put it at the level of the gonion, which is where the mandibular ramus meets the mandibular body. It's that angle of your jaw. And by doing that, I'm able to see an image of the entire body of the mandible. Or sub for zygomatic arch, I can bring the X-ray beam up even higher so that it's planing about 1 inch posterior to the outer canthus. And this should give us good results for zygomatic arches. What about if your patient cannot extend their head back far enough for the infraorbital meatal line to be parallel to the image receptor? Well, remember I said that between the orbital meatal line and the infraorbital meatal line, there's 7 degrees. So if you can only get the orbital meatal line, then I would encourage you to increase your angulation from 90 to 97 degrees. And while it will be a little tiny bit distorted, but the distortion will be negligible. Boy, I could see both of those zygomatic arches, and I'm really concerned about that one that he told me that he was having trouble on his right side. And I really wanted to get that better. So I wonder, is it worth my while to do a unilateral zygomatic arch? So how do I do that? That's tangential projection, which, as you remember, is the X-ray beam skimming a rounded part, and I need 15 degrees of tilt and 15 degrees of rotation. All right, so let's see what I can do. I'm going to tilt the top of the head away from the side of interest. Oh, but then I've got to rotate the head toward the side of interest. Oh, this sounds complicated. Actually, it isn't. My suggestion is instead of sitting the patient facing directly at the X-ray tube, I suggest that you offset her by about 15 degrees so that when she leans back to put the infraorbital meatal line parallel to the image receptor, tilt is already done. And by doing that, then it's a simple matter of just rotating the head 15 degrees toward the side of interest. And there is that zygomatic arch ready for your imaging. Um, I actually did this in our lab a couple of weeks ago because I wanted to test it for myself. And in fact, it works very well. You can see that I've got the phantom head and I have 15 degrees of tilt on him, as well as about 15 degrees of rotation. And there's the zygomatic arch. And this is one of the images that I came up with, which would be entirely acceptable. I would turn that in. Waters projection. Dr. Charles Waters was an assistant röntgenologist at Johns Hopkins University, or Johns Hopkins Medical Center when he published in the Archives of Radiology and Electrotherapy in February of 1915. And I think the Archives of Radiology and Electrotherapy became the American Journal of Radiology. Dr. Waters, in his paper, indicated that the chin should always touch the plate, the nose of the patient 1 to 1.5 centimeters from the plate. Under no circumstances should the nose touch the plate, and a moderate amount of milliamperage and long exposures should be used. Because remember, this was 1915. And so he suggested 20 MA for 25 seconds. And you can go ahead and do the math on that, but be sure you're sitting down when you do that. Now, typically when we do a Waters projection, we do them upright. So let me take this and let's turn it up and let's take a look at this in a little more detail. To start with, this does not look like 40 inches to me. And in fact, back in those days, 1915, X-ray equipment was not nearly as sophisticated as it is today. And as a result, we were using this beam limiting device. And on the front of that beam limiting device, there was a felt pad that was put on the patient's head and then was sandwiched in between the patient's head and the beam limiting device. Okay, I'm not real clear what the reason for that felt pad was. It may have been for comfort of the patient, and it may have been to mitigate, back in 1915, our equipment was not that sophisticated, and there were reports of some patients got shocks while they were getting X-ray images. Maybe that's why Dr. Waters didn't want the nose up against the image receptor. In any event, some of the things that he described are still what we're doing today. That the mentomeatal line is perpendicular to the image, um, perpendicular to the image receptor and parallel to the floor, and that the central ray exits through the acanthion. So this is all the same. And now it's 111 years that we've been doing Waters projections, and we're still doing them not on a regular basis, but it is one of the more common skull and facial bones radiographs that are requested. So what else can we do with Waters? Well, I promised you an open mouth Waters, and the open mouth Waters is when we position the patient for a Waters projection, we ask the patient to open their mouth. Now, I want you to try that. Go ahead, wherever you're sitting, just go ahead and open your mouth real wide. And can you feel your head go backwards just a little bit? That's no bueno. So what we want to do, in this case, I would put both hands on the side of Megan's head and I would say, Megan, without moving your head, I want you to go ahead and open your mouth real wide. And then if her head does come back, I can hold it and mitigate any changes in positioning. And then I can make my exposure. And what are we looking for on that exposure? Here comes the sphenoid sinus through the open mouth. Here is a maxillary sinus, and here behind the nose is going to be the ethmoid sinuses, and beyond that, the sphenoids. So, from that perspective, open mouth Waters is a good projection to show these sinuses if you can't get the sphenoid any other way. You talked a little bit, I think, about reverse Waters and reverse Waters on a patient who can't tolerate being prone or PA. We can leave the patient supine. I can take my central ray. I can approximate the mentomeatal line. And by doing that, then it's a simple matter of moving the X-ray table so that the central ray is entering through the acanthion. And yes, admittedly, I'm going to get some distortion on my X-ray image, but that distortion will still be diagnostic for the ENT surgeons, whatever it is that they want to see. All right, here's a question, not for you students, because you students know the answer, but for the technologists out there in the audience. For an axiolateral mandible, how much angulation do you need in the central ray? Somebody go ahead and open up your mic. How many degrees? 5, 4, 3. Okay,
15
radio silence.
degrees
Very
with
good. What is it?
15 degrees with 10, so a total of 25.
Okay. You're on the right track. We need a total of 25 degrees. We need a total of 25 degrees of for an axiolateral mandible. But the problem with that is that patients have shoulders. And so if we put 25 degrees of angle on our central ray, it's going to it's going to hit the shoulder. Okay, and that's not going to be good because you're not going to be able to see the entire mandible. So we're going to say to the patient, can you bring your arm down any further? Reach toward the floor a little bit further. Can you get down there? No, I can't. It hurts. Okay, well, let's try something else. Can you take your arm and rotate it backwards? No, I can't. It hurts. What can we do? Because we would like 25 degrees to show this mandible, the mentum of the chin, and again, 25 degrees up. See how it's not about the entrance beam, it's about the exit beam. And the exit beam is going to show the mentum of the chin, and it's going to show the ramus and the TMJ, in this case, on the right side. So what's not well understood, except by the young lady who had the courage to open up her mic and say so, is that we can split the angle between head tilt and central ray angulation. Okay, in this case, you can see that I have 15 degrees of head tilt based on the interpupillary line, and I have embellished that with 10 degrees of central ray angulation, and this is going to give me 25 degrees. Alternatively, you can have any combination of 25 degrees between head tilt and central ray angulation, including taking the head all the way over to 25 degrees of head tilt. And now take a look. We've got all kinds of space, and we're getting the entire, not this side, we're not getting the left side of the mandible, we're getting the right side. Um, Axiolateral oblique mandible. I think that this is still on the board exam. I have never been asked to do one of these. Generally, for the mandible, if I give them an axiolateral mandible, then the physicians have been happy with it. But it is important that you know for the board exam that if we're interested in the ramus, we don't need any obliquity of the mandible. So that would be 0 degrees. If we're interested in the body of the mandible, that horizontal portion where your teeth are, then that is 30 degrees of rotation toward the board. If we're interested in the mentum of the chin, um, then that's 45 degrees of angulation. I've not been asked for that one either. And a tip on mandible, axiolateral mandible, is to ask the patient to stick their chin out just a little bit, and that will often help. Well, a little bird is telling me that it's about time that I get off the air, and so let me leave you with a couple of things. First of all, I want you to remember to disinfect the upright bucky before and after use. Okay, let's not spread and let's not transmit diseases. I want you to remember the positioning lines and occasional CR angle. I want you to remember the positioning light, sponges, calipers, the speed square, and paper cups. All of these things can help you, and I think that you have some of them in your department already. And a speed square for $2.99, I think that that's in the budget. Look for rotation and tilt from 6 feet away. I'm telling you, it will make a difference, and you'll be able to see it much more clearly. And I want you to not be intimidated by skull or facial bones because there's a copy of Merrill's somewhere in the department. I want you to know that you can be that guy. I had a lot of help putting this together. the two lines of student names, and some of them are now graduates and technologists. I also reached out to some of my colleagues from around the country, and I appreciate their expertise and sharing resources with me. I want to thank Samantha for inviting me here today and CSRT for hosting it. But most of all, I want to thank you, ladies and gentlemen, for your very kind attention.
Hey, Rich, thank you so
I
much. What a great presentation.
thank you. I can
Thank
almost hear the wild acclamation and thunderous applause.
Thank you for being here. Uh, before we end the meeting, was there any questions anybody wanted to ask Rich while we still have him?
Let me turn this off so that I can see you all.
I have a question.
Yes, please go ahead.
I'm currently a rising senior attending City Tech, and next semester we're gonna start this call. So, do you recommend any sources that will help understanding skull series and projections? Because I know it's a heavy material. What do you recommend
Have you
anything besides
have you started studying skull yet?
that? In school, no, but I'm starting, yes.
Okay. So skull radiography, typically that's not done in the beginning of the program. Typically that
Yeah.
is done a little bit later on. And you will have the value of the textbooks that you have as well as the lectures that you will attend. And during that, you will have labs where it can be explained to you and give you the opportunity to go through the practice of it. And by going through the practice of it, you will have the chance to practice in lab without making exposures, and that will give you some confidence. So I hope that answers your question and helps.
It does. Thank you so much, Professor Rich. That was really helpful.
Oh, good. Somebody else, any other questions?
Hello, Professor Rich. My name
Yes.
is Uloma. I am an educator myself. This was a phenomenal resource. I teach at Kaiser Permanente School of Allied Health Science, and I had some
Ah,
of my students on here. So you did a phenomenal job, and if this recording is available, it would be phenomenal. Thank you for tackling this subject. It was really good.
well, thank you for the nice compliment. I don't know if this is recorded and if that recording is available, but I am here based in California, and I uh, this talk takes on a much different um, venue if I can come and do it live for you. And so around the country or at Kaiser, if you're interested, my contact is up there.
Okay, I will reach out to you. Thank you. And
Thank
we're
you.
Rich,
we're located in Northern California, so we're in
Down in
Richmond.
Richmond?
Yes, I'll
Yes, I
be
know it. I've been there.
okay. Perfect. We'll be in contact. Thank you.
Thank you.
Rich, can you hear me?
Yes, I can.
Have you ever heard of a Zimmer view?
A Zimmer view.
Yes.
I have not. What is it?
Well, I actually stumbled on it by mistake. I thought I had come up with a brand new view when I shot a individual condyle or head of the mandible through the orbit on a
Oh,
TMJ series, and the radiologist was all excited that read it. He said, "I haven't seen a Zimmer view since 1968." I'm thinking Zimmer view. I thought I came up with this on my own. So it just goes to show you. Yeah, it was discovered in 1912, and he said they didn't do it that often because it didn't turn out that well. I got lucky and turned out. It's just a matter of turning the head. It's like an AP skull, but you turn the head inward to the opposite side of interest, about 20 degrees, angle down 20 degrees, and angle through the orbit and collimate around the orbit, and then you open up the mouth, and it drops the condyle
right.
down and over the or aligned to the orbit. It's a great shot if you ever have to have an individualized shot of the condyle and the neck of the condyle. So
I've
it's
not,
called a Zimmer view.
thank you. I've not heard of that one, but I am going to go ahead and look it up.
All right.
Appreciate it.
Hey,
Yep.
Rich. Rich,
Yes.
it's Angela.
Hello, Angela. Nice to
Hi.
hear you.
Nice to always see from you, and bravo, this was amazing. Thank you.
Thank you for the compliment. I appreciate that, Angela.
Miss you.
Thank you. I miss you too, and all the gang.
Hi, Rich. It's Barbara. I miss you.
Barbara, how are things in Pasadena?
They're good. We have awesome students. Second years are almost ready to graduate, and first years are going. We just covered skulls just this past couple weeks. So this definitely helped.
Well, good. I hope that they all get A's on your exam, and I hope that they get the opportunity to do some of this stuff before they
Well,
graduate.
hopefully, but it sounds like skulls are few and far between anymore.
Yes, that's true, but by the same token, they're still out there.
I know, I know. Well, good talking to you. Keep in touch.
Thank you. Good to hear you.
Rich,
Yes.
one other thing. I worked at a clinic where they had a lot of people, a lot of patients came from Southeast Asia and Africa, and they couldn't put them in the CT scanner because they had shrapnel either in their neck or somewhere in their head region, on the scalp line. And so consequently, we did a lot of head work because of that.
Hmm.
So it's just another reason why you shouldn't give up your skills if you have that kind of a patient population where they came from another country where there was a lot of warfare and whatnot, and they might
That's
have been subjected to various types of weaponry.
that's a good point, and I hadn't thought of that. I may have to incorporate that.
Now
Appreciate
the same thing with mastoids. They want to take them off of the codes. We never do mastoids. Well, sometimes we had to because there was shrapnel in the head region, and they couldn't put them in an MRI or a CT
Yeah,
scanner.
yeah. So you can still find references to mastoid and some of the things that we didn't do, auditory ossicles and stuff in the older editions of Merrill's. All right, anyone else?
Hi, Rich. I just wanted to say great presentation. It's
That
Megan.
sounds like Megan. I
It
thank you very
is.
much. I appreciate it, and I appreciated your help when we did those pictures all those years ago.
Of course, it was fun.
Good. Good to hear you again. Anyone else out there? I
Rich, my name is Hike. It's nice to meet you.
Hello, Hike.
I just wanted to say thank you for the presentation. Thank you for your time. Thank you for the information. Uh, additionally, I mean, if you were to do any future presentations,
Yeah.
how would I get a notification for that?
Um, I may be going to the CSRT annual conference in October. I have offered another one of my talks to do down there, and so we could, that'll be hopefully coming up, and we can certainly talk about this one at that time if you're able to attend that conference.
All right, that sounds good. Can you repeat that one more time for me, please? You said it was a CSRT?
Yes, California Society of Radiologic Technologists, with whom I am affiliated. And I have done a fair number of presentations over the years for them. And so this was another opportunity. I wanted to do this for the students because I know that students are acutely interested in this stuff.
Rich, this should also be your plug that aren't you still the editor of the Technogram?
No, Angela, as I'm getting on in years, I had to let some things go.
Okay, I thought you were still doing that. Sorry.
It was wonderful in my time, but you know, you need to move on. Anyone else? Other questions? If there's any technologists out there from around the country and you're interested in perhaps hearing this talk at your annual conference or even live, do let me know on my contact rlara@gurnick.edu. Alex, Sam, back to you.
All righty. Well, before we end the meeting, Sam, was there anything else that you wanted to add?
Not much. It's just our CSRT conference will be October 24th to October 25th in San Francisco. Save the date. You will get information on also for those who want the recording. Once the link is ready, I can share it out to those of you who want it. And I think that's all I have
So
for now.
that last patient didn't show up.
Yeah.
Okay, so you guys are done. Okay, cool. All right, perfect.
Alrighty.
And also, if any of you guys are interested in speaking at future student committee meetings, feel free to reach out to CSRT and we can make that happen for you guys.
Well, very good. I'm going to sign off now. Thanks again for inviting me. I really did enjoy this, and I'm hopeful that this goes toward better patient care as the students become technologists and they remember this talk.
Thank you,
Well,
Rich.
Thank you.
thank you so
Rich.
much for presenting. It was amazing.
Thank you for inviting me,
Of course.
and I will see you at the next one.